Today, I would like to present a challenging case of revision lumbar spine surgery in a patient with long-standing mechanical back pain and lumbar radiculopathy. The patient presented with persistent severe mechanical low back pain and right-sided lumbar radiculopathy, despite two previous lumbar decompression surgeries. The clinical presentation was consistent with persistent spinal pain syndrome type 2, previously known as failed back surgery syndrome. Case presentation. The patient presented with a history of 15 years of disabling mechanical low back pain with right-sided lumbar radiculopathy. Past surgical history revealed previous L3, L4, and L4, L5 decompressive laminectomies. Also, a removed L5-S1 spinous process. Despite this surgery, the symptoms persist with a failed medical management. On clinical examination, severe mechanical back pain, right L3, L4, and L4, L5 radicular pain, heel and toe walking limited by pain, no major motor deficit perioperatively was recorded. From imaging studies, previous decompressive defect was detected on MRI sagittal T2 scan and axial T2 scan with L3, L4 disc herniation at the current presentation. Also, degenerative changes at L3, L4, L4, L5 was noted. This CT scan of the lumbar spine showing severely degenerative spine with the previous defects from previous lumbar surgeries, also with a vacuum phenomena. Decision making. Despite the absence of instability, although radiological instability was not demonstrated, this patient had persistent spinal pain syndrome type 2 following previous lumbar decompressions, recurrent disc pathology at L3, L4, extensive prior posterior surgery, and persistent disabling symptoms. Despite comprehensive conservative management, made revision decompression and discectomy alone not in favor of the patient's current condition. A revision TLIF allowed circumferential neural decompression, complete discectomy, restoration of disc height and segmental lordosis, interbody fusion and stable fixation of the previous operated motion segments. Operative technique include the following: revision exposure, pedicle screw placement, adhenolysis around the dural and nerve root, fascicectomy, discectomy, endplate preparation, banana cage insertion, rod fixation, also a final fluoroscopic conformation. This intraoperative fluoroscopic view showing or 6 transpedicle screw placement in favor of restoring lordosis. Also, this fluoroscopic view showing banana cage inserted at the corresponding level L3, L4, L4, L5 lumbar spine segments. An intraoperative video will be played showing the insertion of banana cage. Post-operative CT scan showed a transpedicular screws at the corresponding level. The outcome of this surgical intervention, the VAS score improved from 7 out of 10 to 4 out of 10 immediately after surgery. By post-operative day 2, significant action of radicular pain, independent ambulation, heel and toe walking restored, motor power 5 of 5 bilaterally, no new neurological deficit. The patient was discharged post-operative day 4 with no neurological deficits. The take-home message: revision lumbar surgery should not be guided solely by imaging. Successful decision-making requires integration of the patient's symptoms, neurological examination, previous operations, imaging findings, and failure of conservative treatment. In carefully selected patients with persistent spinal pain syndrome type 2, revision TLIF can provide meaningful pain relief and functional recovery, even in the absence of radiologic instability.